Hello, my name is Anna Marks, and I'm going to be talking about hyperlipidemia in the adult populations. Some key points I'm going to touch on are what is hyperlipidemia, the Healthy People 2020 goal, and then the effects of hyperlipidemia. The Healthy People 2020 goal I chose falls under the heart disease and stroke category, and the objective is to reduce the proportion of adults with high total blood cholesterol levels. So this objective measures the percentage of adults aged 20 and over who have hyperlipidemia. Hyperlipidemia is an abnormally high concentration of fats or lipids in the blood. So in 2004, 16.6% of adults had hyperlipidemia. The Healthy People 2020 target was to reduce that percentage to 13.5. So that goal was met in 2008 with the percentage being 13.5, and it has continued to decrease with the last percentage being 11.7 in 2016. So just as a refresher, total cholesterol above 240 is considered high and less than 200 is considered desirable. All right, so a practice implication that needs to be changed is disease surveillance. So with hyperlipidemia being a major risk factor for cardiovascular disease, disease surveillance is needed to help prevent cardiovascular disease and also to measure trends. So on the Healthy People 2020 website, they mentioned that no national system exists to collect data on how often cardiovascular events occur and also on how often they result in disability and diseases. So that's something that can be changed on the national level. On the state level, disease surveillance can be used to collect data so that we can better identify local populations who may need more intensive interventions, like patients who fall under the vulnerable population category, like patients in poverty or the elderly. By primary prevention, I really am talking about lifestyle changes here. So prevention of hyperlipidemia by lifestyle changes is a practice that can be implemented on the individual level. So actually on the Healthy People 2020 website, I was browsing under the nutrition and weight status, and under one of the objectives, they said that only 11.5% of physician office visits by adult patients with a diagnosis of cardiovascular disease include counseling or education related to diet or nutrition. Uh, and I thought that was pretty alarming, especially since we know that things like diet, nutrition, physical inactivity, smoking are all lifestyle choices that affect hyperlipidemia. In the office setting, we really need to be educating our patients on those lifestyle risks. And then current health policies. On the American Heart Association website, they list that most healthy adults should get their cholesterol checked every 4 to 6 years. And then they also mention people with a history of heart disease, history of diabetes, and patients that have a family history of hyperlipidemia. They need to get their cholesterol checked more often, but a specific time frame is not listed on the American Heart Association guidelines. Okay, so here I just included a graph that I found on the CDC website that shows the prevalence of high total cholesterol between adults and then male or females. So you can see on the graph on the right-handed side, women age 40 to 59 have the highest prevalence of high cholesterol. Okay, so here is a second graph that I found on the CDC website that just shows the correlation between age and cultures for high cholesterol. So you can see over on the right side of the graph, non-Hispanic white women have the highest rate of high total cholesterol, and then Hispanic women have the lowest. Okay, so how hyperlipidemia relates to the general population. So we know that having high cholesterol is a major risk factor for cardiovascular disease, since having high cholesterol causes atherosclerosis or plaque buildup in the arteries. Cardiovascular disease is the leading cause of death in the United States, And I feel like it is a disease process that can be prevented with modifying the lifestyles of our patients. And then hyperlipidemia affects the quality of life because it is such a major risk factor for heart attacks and strokes. And having a heart attack or a stroke can lead a patient to having decreased quality of life due to living with any deficits that were caused from the heart attack or a stroke. All right, so two vulnerable populations I'm going to be discussing are the elderly and the socioeconomically disadvantaged. So in the elderly population, they are more likely to have a sedentary lifestyle, and that can be due to diseases and disabilities, for example, arthritis. So this can prevent them from having the regular exercise that can be needed to reduce cholesterol. Also, the elderly patients may be more sensitive to side effects of drugs. Um, in older adults, statins, the lipid-lowering drugs, can have the side effects of gait disturbances and muscle weakness, which could lead the patient to fall. So this is definitely something that the patient and provider need to collaborate on to find the best treatment plan. And then with socioeconomically disadvantaged, these patients may not have access to healthy foods. They may not have access to fruits and vegetables. So they may be eating a diet that's high in processed foods, high in saturated fats, high in trans fats. So we definitely need to educate the patients on the importance of a healthy diet and also work with the community to see if there's any resources for these patients. Anything like a farmer's market that may be walkable if they may have trouble with transportation to a grocery store. These patients may also have problems with access to health care, meaning they're having difficulty getting into a primary care physician, making it to their doctor's appointment. So that can prevent them from having regular cholesterol checks. And then also the cost of drugs. So if they are prescribed a lipid lowering drug like a statin, are they able to afford that drug? All right, well, this is the end of my presentation. Thank you for listening.